So in my practice, I keep coming back like a broken record to the general philosophic reasons why we treat lung cancer, including when we treat for cure, our preferred way to treat when we can. There are really only two reasons that we treat. One is we want our patients to live longer than if we did nothing, or if we did an alternative choice to whatever we're considering. And perhaps even more importantly, we want to improve quality of life compared to doing nothing, or compared to an alternative choice. The duration of life piece is obvious to most folks, particularly with stage 4 lung cancer. If you knock a cancer down, you live longer than if you let it grow through you. Quality of life is more complex. And at first glance, those who haven't had a long relationship with lung cancer or another cancer, the first thought is, well, isn't the kindest thing to do nothing? Wouldn't that be the best quality of life possible? And this comes from an accurate perception that our chemotherapy has side effects, right? These are very famous: nausea and vomiting, hair loss, fatigue, amongst others. The problem with that simplistic way of thinking is that this is the other half of the quality of life equation, which is that lung cancer itself causes a lot of suffering as it grows. When it grows in the brain, you get nausea, vomiting, headaches, and confusion. When it grows within the lungs, you get shortness of breath and cough, the subject of a full talk later. And anywhere in the body it spreads, it can cause pain. And so these are the kinds of things that we're trying to prevent when we say improve quality of life. And when we think globally about quality of life, taking suffering from any cause as being equivalent, a good treatment then is one that has a minimum of side effects, minimum of harm in the treatment, and a maximum of cancer control to prevent harm from the cancer. And in stage 4 disease, we really never have the luxury of considering either of these elements of suffering in isolation. The tools that as a medical oncologist I have at my disposal to control cancer are all medicines. And they come in 3 classes: chemotherapy, targeted therapy, and immunotherapy. Chemotherapy is poison, but it's poison with a very specific mechanism of action, which is to say that it poisons rapidly dividing cells. The majority of non-cancerous healthy cells in the human body do not divide. They sit put and do their job. In contrast, cancer cells, by their very nature, divide a lot to spread and grow, and so they're preferentially affected by the poison. The brain accurately recognizes chemotherapy as a poison, which is why chemotherapy can have nausea. As well, any cell that has to divide in the body to do its normal job can also be affected by chemo. This is why, for example, blood counts, the white cells that fight infection, the red cells that carry oxygen, platelets that help us to clot, can decline in numbers with chemotherapy because they divide to make new ones. As Dr. Paco mentioned, there's a basic formula to how to do this. There are the platinum drugs are the cornerstone of standard chemotherapy for the first treatment that a lung cancer patient gets. And there are 2, cisplatin and carboplatin. For incurable patients, which unfortunately is the majority in non-small cell, I always use carboplatin in my practice. And this is for simple human reasons. Cisplatin has a marginal efficacy edge over carboplatin. We're talking additional survival of a week or 2, but radically higher toxicity profile. A lot more nausea, nerve damage, kidney damage, hearing loss, ringing in the ears. And from a human perspective, I feel quite strongly that carboplatin is a more favorable agent in that human equation. There are numerous partner drugs. We're about to talk about data on why nanoalbumin Nab-Paclitaxel may have some superiority compared to other agents in squamous histology. And Necitumumab is a targeted therapy that may have some efficacy. One thing that I want to point out is there are 2 drugs that should not be used for squamous histology. Pemetrexed, because it doesn't work. While this is a fine drug for non-squamous histologies, it's near placebo for patients with squamous histologies and should not be used because of the lack of efficacy. Bevacizumab, a fine drug for non-squamous patients, has a 1/3 rate of fatal hemoptysis when given in squamous carcinoma, obviously unacceptable. So pemetrexed and bevacizumab should be avoided. Do we have drugs, though, on a more hopeful note, that actually might work better in squamous patients? Yes, even before we get into the fancier, newer stuff, we do. In the realm of chemotherapy, my first mentor here, Mark Szynski, ran a trial randomizing patients unselected by histology, these are stage 4 patients, to carboplatin and paclitaxel, or carboplatin and nanoalbumin-bound paclitaxel. Survival was identical, including in subgroups for squamous or non-squamous. So a squamous patient does not have better survival with this agent. However, what the advantage was in response. So response has a funny definition in the oncology world. Response means a 30% shrinkage of cancer by a system called RECIST. Technically, 1% shrinkage to 29% shrinkage would be called stable. So the percentage of patients who have this nice shrinkage of 30% or more was quite a bit higher in squamous patients with a nanoalbumin-bound paclitaxel than with a standard paclitaxel. Why does this matter in the absence of a survival advantage? It all comes back to quality of life as we discussed earlier. Cancer causes symptoms, and squamous cancers like to grow centrally in the chest, where they can press on airways and they can press on central vessels. And for many of our patients, shrinking the cancer can result in an improvement in quality of life. And that's why we care about this. Necitumumab is a targeted therapy. It's IV. Its target happens to be called EGFR. And this is a randomized study of patients who got cisplatin and gemcitabine, shown in blue, or cisplatin and gemcitabine plus this targeted therapy, Necitumumab. What you can see here is that there was a small but meaningful survival advantage with Necitumumab. How do I integrate this in my practice? Well, I think if cisgem is your backbone, it is good to add Necitumumab for this survival improvement. I have not integrated this into my practice simply because, as I expressed earlier, I don't use cisplatin for incurable patients. But there are ongoing studies evaluating the use of this antibody in combination with other regimens that I anxiously await the results of. So this is actually a slide a little bit more about adenocarcinoma. What you see at the left here is a randomized study of standard chemotherapy compared to a targeted drug called gefitinib, done in unselected patients. And what we learned years later after the trial was done, that in patients without mutation, the targeted therapy looked like placebo. So if you don't match target with targeted therapy like a lock and key model, you don't get activity. In contrast, what we saw on top was that when you do have that fit, when you match target with targeted therapy, wonderful things happen. You have more convenient, less toxic drugs that work better. And for those of us that care deeply about squamous cancer, as all of us here today do, this is the kind of advance that we felt a little bit left behind on. But there are targeted therapies coming in limited ways to squamous cancer. We spoke earlier about Necitumumab, and I'm looking forward to seeing data on that with chemo backbones that are more tolerable. A newer change, just very recently discovered, MET amplification, occurs both in squamous and non-squamous patients, with limited data showing that when it's amplified in squamous, treatment results might be fairly similar to non-squamous patients. And these are just the waterfall plots. This is just showing shrinkage in patients with high levels of amplification. So there may be some limited targeted therapies coming to squamous cell carcinoma. Some of these are being investigated now. But here's the biggie. This is where you really have to be enthusiastic, and where, in a sense, it's better to have squamous than non-squamous disease, finally, immunotherapy. So in order for a cancer to grow, it needs to evade the immune system. So in this way, any clinically relevant cancer, any cancer that's big enough that doctor and patient know about it, could be seen as a failure of the immune system. And I hope some will forgive me for oversimplifying a little bit, but one way that cancer hides from the immune system is by expressing this molecule called PD-L1. It acts kind of, in a simplified sense, could be viewed as an invisibility cloak for cancer cells to hide from the immune system's effector killer T cells. And I apologize to the scientists for the gross oversimplification. Lung cancer, squamous lung cancer being the second cancer right after melanoma to get effective immunotherapy, makes kind of common sense. The mutational load is the highest in melanoma, the most perturbations, the most things that are different about it compared to a healthy cell that the immune system can potentially see. And that melanoma was indeed the first cancer to get effective immunotherapy with drugs like IL-2, Nivolumab, and now the PD-1 inhibitors. And lung, squamous lung, just right behind with impressive efficacy for these drugs. So you may ask, well, show me the money, right? Where's the real clinical data that you're helping patients? And here it is. So this is a randomized clinical trial. Half the patients get one treatment, half get the other. And it was 4 patients in second line. So this is stage 4 patients who had gotten a platinum doublet and their cancer had now grown. There, the most common standard of care is a chemotherapy drug called docetaxel, and it was compared to the immunotherapy drug Nivolumab in a head-to-head study. And what you see here is a survival curve. So Nivolumab beat docetaxel for survival, actually quite handily, and perhaps even more importantly than beating the average is the tail of the curve. Most of my patients come into the office, and when we're talking about advances, what I keep hearing is patients asking for a chance of being alive years down the road, not in an extra week or an extra month. I mean, we'll take it. But what people are really excited about is trying to live for years, and this drug and this class are the first to really offer a high and legitimate hope for that. You might ask, well, what toxicity cost? None. Nivolumab was far less toxic than docetaxel. Typically, our placebos in placebo-controlled trials have more severe toxicity than what we're seeing here for Nivolumab. This drug and its sibling drugs are not risk-free or toxicity-free. They're far gentler than the previous standard, but they do have side effects. Most commonly, they're autoimmune, since it's an immune-stimulating drug. Most commonly, fatigue, autoimmune endocrinopathies, which means disruptions of hormones like the thyroid. And the 2 most feared ones are autoimmune effects in the lung that we call pneumonitis, and autoimmune effects on the colon that we call colitis. So not risk-free, not toxicity-free. There's monitoring that is required that if you receive one of these drugs, your doctor will do for you, but globally, way gentler than the previous standard of care. In non-squamous cancer, we had these biomarkers that Dr. Paco showed you earlier, that I showed. If you have a mutation and you match it with the targeted therapy that actions that, wonderful things happen. Could we do the same thing here with Nivolumab and its sibling drugs, right? They're maybe better than chemo, but could we stratify down to the patients who benefit the most and those who don't benefit? The leading candidate biomarker was the target itself, PD-L1, and we see that as studied in this large phase 3 study, there was no patient population, even the non-stainers, the complete non-expressors, at least by this lab test, who didn't do better with Nivolumab as compared to docetaxel. And so in my practice, I am not using this biomarker, at least in second line, to determine who should get immunotherapy. Similar experiment has been done with another now FDA-approved drug, pembrolizumab, with very similar results, that it beat docetaxel. And I think the approval was too recent for my slide deck, but now a third drug as well, atezolizumab, all with very similar results. All 3 agents beating chemotherapy in the second line and with less toxicity. So this is truly breaking news. This was first reported just a few weeks ago at European Cancer Nerd Conference called ESMO. This is a randomized clinical trial in first line, so the first treatment that a stage 4 patient gets, randomizing patients with a very high level of expression of a different version of that PD-L1 biomarker to either chemotherapy and pembrolizumab, or pembrolizumab, excuse me, another PD-1 inhibitor. The allowed were most of the standard doublets. The Nab-Paclitaxel that we discussed as being particularly efficacious for squamous patients was not an allowed agent on this trial, but otherwise all the standard regimens were there as options. And in this highly selected population, immunotherapy handily beat chemotherapy. This is a really big deal. This changes the standard of care for squamous non-small cell lung cancer. As of these results, every stage 4 squamous non-small cell lung cancer patient should have their PD-L1 tested in frontline, and if it's 50% or higher, and if there are no contraindications like pre-existing autoimmune diseases, that patient will live longer with pembrolizumab as compared to chemotherapy, and will have a higher chance at that durable cancer control, at trying to be alive years down the road. And the toxicity in this study was a lot like what we reviewed earlier for second line. That last slide, excuse me, just to clarify, is progression-free survival. So this is about cancer control on this slide, and the next one is survival. Very fortunately, an immature curve, meaning that most of the patients are still alive and being followed for survival. A wonderful problem to have immature data for survival early in the study. What about the subgroup analysis? Academics love to torture clinical trial data into confessing something. When we compare squamous to non-squamous patients here, we see, if anything, a trend towards superior benefit for squamous histology. I'm going to move on here in the interest of time and talk about adjuvant therapy. So we've been talking thus far about stage 4 disease, but some lung cancer does present at curable stages, stages 1 through 3B. But we can see here at a glance that the cure rates are not nearly as high as we'd like them to be, leading us to ask after surgery, what else can we do? Well, what we can do is chemotherapy. Chemotherapy can add an average of 5% to survival at 5 years. Not as high as we'd like it to be, but we are talking about survival here, a very meaningful endpoint. And this is indicated for patients with node-positive cancer or cancers at least 4 centimeters. And we have a number of trials trying to add to chemotherapy to try to do yet better, including clinical trials looking at the immunotherapy agents. It is obligatory to end talks with pictures of your cute kids. This is a month ago, my twins, Betty and Dina, and also put up because some of the folks from Cancer Grace had asked for a picture of them. So with that, I'm going to stop and get at some of these questions. So I think we've addressed the question of whether there are better or worse choices for chemo for squamous lung. If PD-L1 is at least 50%, immunotherapy better than chemo, and at least for response, Nab-Paclitaxel better than paclitaxel. And finally, when cisplatin and gemcitabine is used as the backbone, Necitumumab, a good targeted therapy to add, perhaps with other doublets, data to come. The next question here is, should immunotherapy be the first treatment patients get? What we know right now is that it should be if PD-L1 is at least 50%. Less toxicity, better average survival, and probably better long-term survival than chemotherapy for that group of patients. And there are all kinds of cool immunotherapy trials for squamous histologies coming down the pipe that I'm going to defer talking about because I suspect Dr. Paco will get to them. And finally, what about Tarceva and afatinib? So this is a kind of complex and controversial question. Tarceva or erlotinib is a first-generation EGFR tyrosine kinase inhibitor, so it's a targeted therapy. And the data on erlotinib in patients who don't have that mutation, who don't have that lock and key fit, is really for limited to no efficacy. There's controversy over whether you have very limited efficacy or whether it doesn't work at all. That question used to be of more interest to me as a clinician passionate about squamous lung cancer, but in the era of immunotherapy and all the exciting trials that Dr. Paco is going to talk about, I've kind of lost interest. It's to me, just not good enough for me to use in my practice at the current time. Afatinib does have some squamous specific data that can result in it being considered as a treatment choice. But there again, I think the limitations there are the more exciting results that can be achieved with immunotherapy, including immunotherapy trials that are leading me to steer patients there a bit more, as well as the superior toxicity profile of immunotherapy compared to that agent. Is there any immunotherapy drug that does not have side effects such as severe pneumonitis? No. It is a risk with all of the agents. That risk is low, perhaps at or a little bit under 1%. If you really wanted to torture this, trying to compare across trials, the numbers can be a little bit different. I'm not entirely convinced that that's a real effect that I would speak and say you should use drug X instead of drug Y to avoid pneumonitis. I would say that it should be monitored for very carefully in clinical practice. So a patient on immunotherapy who becomes short of breath, particularly suddenly, deserves evaluation not only for pneumonitis, but other competing causes of shortness of breath, such as pulmonary embolus or an airway being clipped off. And I'm not going to speak more about this because we have a genuine expert on the subject of shortness of breath who'll speak more. But when you get on these quickly and you treat them aggressively, not only can you keep patients safe, but there's data that you can even get patients potentially back on treatment and have them benefit. And so the key thing, if you're on one of these drugs and you become short of breath, is to let your doctor know right away. And I would also say that given the more global side effect profile of these agents compared to the alternatives of doing nothing or of chemotherapy, they're quite a bit favorable. And I wouldn't let that small risk stop an otherwise appropriate patient for considering them. The one caveat is that with interstitial lung diseases, and your doctor will help you to know which is which, there should be perhaps a greater note of caution, and many would argue these drugs should perhaps not be used. Next question is, what about anti-PD-1 and CTLA-4? Correct me if I'm wrong, but I think Dr. Paco has, no? Are you talking about that, or?
You can talk about it.
I can talk about it, great. So there are multiple ongoing studies looking at the combination of two checkpoint inhibitors. So PD-1 is a relatively late event scientifically in a T cell's activation. CTLA-4 is involved mechanistically a little bit earlier. CTLA-4 has drugs that are improved in melanoma, where it's been a more exciting single agent target than in lung cancer. But there's some really early data in lung cancer with a small number of patients suggesting that when you add a CTLA-4 agent to a PD-1 agent, that really wonderful things can happen, that these can be very, very effective. We don't know how true this is. It's early data. But there are multiple ongoing phase 3 trials addressing this question of what a CTLA-4 inhibitor might add to the existing PD-1 inhibitors. It's an area of very high promise and an area that we should have answers within the span of the next 2 years. So it shouldn't be done in clinical practice, but if a patient asks, is this a trial that I should consider high promise, that would be worth traveling for example, the answer is absolutely. There are multiple questions about targeted therapies in squamous and why no mutation testing for squamous. I'm going to start that answer, but invite Dr. Paco, who's a much better scientist than I could ever hope to be, to contribute further if there's more to say. Squamous cancers are far more biologically complex than non-squamous cancers. In a non-squamous cancer, you can sometimes identify a single mutation that happened early in the life cycle of that cell going from healthy, useful, happy cell to cancer cell that was really important in that transition. And then you got the works of that really important mutation and good things happen. When I think of squamous cell, I think of them as having a lot more little mutations that added up to produce that lung cancer. Complex to the level that we need people like Dr. Paco to try to understand them, that we're not going to say, oh, it's event mutation A or B, and if we've done that up, it's going to help. There are some detectable changes. There are none that have FDA-approved therapeutics at that time, but people are studying a few of them with hopes that there might be effective therapies. These have targets such as FGFR2 and PI3 kinase. There are none that are clinically applicable as standard of care right now, but there are some people trying very hard in research. I would say that here, I think we put more of our research eggs in the basket of immunotherapy for reasons of the data that I've shown thus far.